A hospitalized patient is suddenly producing dangerously little urine. When kidney function rapidly declines like this, we are usually looking at one of two primary physiological culprits: pre-renal acute kidney injury or acute tubular necrosis, known as ATN. In a pre-renal state, the kidney is severely underperfused, but its internal architecture remains intact. ATN is defined by structural damage to the renal parenchyma itself. The cells lining the kidney's tubules are actively dying. Telling these two apart dictates the course of treatment. Misdiagnosing ATN as a pre-renal state and aggressively administering IV fluids leads to volume overload. Making the reverse error starves a salvageable kidney. To differentiate these two states, clinicians rely on a standard diagnostic matrix of urine indices, commonly found in Table 29.5. If this table is merely memorized as a list of numbers, it leads to errors on the wards. Rather than memorizing these indices, they should be derived from the first principles of tubular physiology. Understanding the physical state of the nephron is the only way to read the data accurately and avoid the traps hidden within the raw numbers. The nephron's primary defense mechanism against volume loss is the aggressive concentration of urine. This split screen compares the two states. On the left, the pre-renal response. The nephron is intact. It reabsorbs water back into the body, concentrating the urine to a specific gravity exceeding 1.018. This drives osmolality above 500, confirming the hypertonic medullary gradient is functioning. Compare that to the ATN state, where the concentration engine is mechanically broken. The damaged proximal and loop cells lose structural integrity. They physically cannot maintain the chemical gradients required to move water. Without reabsorption, the urine concentration matches the blood plasma. We call this isosthenuria. The specific gravity stalls near 1.010, and osmolality hovers around 300. Beyond these chemical gradients, the physical debris left in the urine sediment provides another direct readout. This microscopic illustration shows a transparent, benign hyaline cast. These are the expected byproduct of the concentrated, sluggish flow found in a healthy pre-renal environment. Contrast that with the debris of ATN, the dark, muddy brown granular cast. These casts are the physical remains of necrotic epithelial cells that have died and sloughed off into the tubular lumen. Specific gravity, osmolality, and the sediment readout provide physical proof of whether the medullary gradient and epithelial lining are intact or destroyed. While concentration metrics confirm the gradient, the definitive readout of tubular health is how the kidney handles sodium. Many clinicians evaluate this by looking at the raw urine sodium concentration, but that value has a critical mathematical flaw. Raw urine sodium fluctuates based on how much water is simultaneously being reabsorbed by the kidney. To isolate tubular pump function, we use the fractional excretion of sodium, or FeNA. This is the FeNA equation. It measures the percentage of filtered sodium exiting the body, bypassing water's diluting effects. The denominator represents the total filtered load of sodium presented from the blood. The numerator represents the actual excreted amount of sodium in the urine. When applied to the pre-renal state, the results are clear. Intact, volume-starved tubules actively reabsorb almost all filtered sodium back into the blood. This drives the FeNA to less than 1%. In the ATN state, the result is the opposite. Necrotic, pump-deficient tubules cannot hold on to it. They leak sodium into the urine, resulting in FeNA greater than 2%. While the less than 1 and greater than 2% thresholds are the standard, trusting this math blindly in critical care creates a diagnostic trap. Consider our first clinical paradox. A volume-depleted pre-renal patient presents with a FeNA of 2.5%. The important clinical context here is that this patient was recently administered a high dose of intravenous loop diuretics. Look at this nephron loop. Loop diuretics block the sodium-potassium chloride cotransporter in the thick ascending limb. This forces sodium ions to bypass reabsorption and dump into the urine. Sodium excretion here is chemically forced. This elevates the FeNA above 1%, even though the tubule itself is intact. The physiological workaround for this trap is the fractional excretion of urea, or Fe-urea. Urea reabsorption happens in the proximal tubule, making it immune to the loop diuretic blockade further downstream. An F-urea of less than 35% confirms a pre-renal state. Even when diuretics skew the sodium data. Now, consider a second paradox. A patient has ATN with muddy brown casts, but a FeNA of only 0.4%. This typically occurs in early ATN following a radiocontrast procedure or an episode of severe rhabdomyolysis. This diagram shows the mechanism. Radiocontrast and pigment toxins cause vasoconstriction of the renal arteries. Clamping blood flow reduces the initial filtered load of sodium. With little sodium entering, the calculated FeNA is forced below 1%, masking the downstream tubular necrosis. Sepsis can also trigger this same low FeNA ATN phenomenon. FeNA is a precise metric, but chemical blockers and vasoconstriction can override the math and mask the state of the epithelial pumps. Table 29.5 acts as a clinical dashboard, categorizing these data points by the specific physiological function each index measures. The concentrating indices form your first line of evidence. Specific gravity and osmolality prove that the kidney's medullary gradient is functioning. Next are the fractional excretions. FeNA and Feurea prove that the epithelial pumps are actively retaining vital molecules. Finally, the microscopic sediment. These casts provide physical evidence of either healthy concentration or active cellular necrosis. No single metric from this table can be treated as an absolute diagnostic truth in isolation. Diagnosing acute kidney injury requires synthesizing these functional readouts against the patient's unique pharmacological and vascular reality. By interpreting the raw data through the lens of cellular physiology, the clinician can derive the diagnosis from the physical state of the tubule.